Good morning, everybody. A very fresh morning. Warm welcome to all the RV Dental College team, as well as the alumnus team, and also, of course, the international presenter, Dr. Priya Madam. So, here is the interesting onboarding talk that I would like to present. Warm welcome to the Orofacial Pain, a Clinical Perspective, Part 7. It is indeed a very energetic Dr. Priya Madam who at every week is making her presentations. So I am Sunil Chiplonkar. I am as the VP Business Development with Group Pharmaceuticals. We present an array of interesting products that partner dentists in providing good services to their patients. If you look at the history of dentistry in India, there are very interesting points to be seen. In 1000 BC, the Sushruta Samhita gives numerous descriptions of severe periodontal disease, which has been characterized by loose teeth and purulent discharge. And if you go to the Indus Valley civilization too, there are records and evidence of dentistry being practiced, even as far as back as 7000 BC. So there were various tools that have been used in the Indus Valley civilization for their dental practice. The Egyptians too used to practice dentistry, and in fact, the person who practices dentist was called the chief of toothers. There is a Egyptian text called Eber's Papyrus, which refers to the diseases of the teeth and the various toothache remedies that can be utilized. So dentistry has a very long and hoary history. The Chinese has also been not quiet. Right from 2000 BC, they have been practicing dentistry, and they were inventors of the silver amalgam paste for the dental fillings. In 16th century, it was Pieri who is considered to be the father of modern dentistry, and he developed dentistry as an independent profession from medicine. In 1723, he published The Surgeon Dentist. John Greenwood was the interesting personality who first constructed the dental foot engine, which has been kind of improved. This is the prototype of the first dental chair. Josiah Flagg, a prominent American dentist in the same year, has also constructed the dentist chair with the adjustable headrest. Richard Skinner, he published a book in 1801 as the Treatise on the Human Tooth, the first book published in America. Samuel Stockton, he began the commercial manufacture of the porcelain teeth in 1825. Then we have the Crowcar brothers who introduced the amalgam in the United States, and they advertised it as a substitute for gold restoration. So the American Society of Dental Surgeons then denounced the use of the amalgam, and in dental history, this is known as the Amalgam Wars. The world's first dental journal is the American Journal of Dental Science, which began publication in 1839. Charles Goodyear, who invented the vulcanization process of hardening the rubber, and thus they could create the vulcanite, which is a material that could be molded to the mouth shape. Horace Hayden, Chaplain Harris in 1839 established the world's first dental school, the Baltimore College of Dental Surgery, and the Doctor of Dental Surgery came into being. Horace Wells, a Connecticut dentist, he discovered the use of nitrous oxide as an anesthetic agent. Then we have the first dental laboratory in New York City in 1854, which was established by Wadsworth, and he got the patent for the first toothbrush. So that was when the first toothbrush was introduced. There are so many now dental products available for oral hygiene and improvement of dental health. Reason is the mouth is the gateway to both health and disease. So it's a very important aspect to note. We at Group Pharma have offered several dental products for the improvement of dental hygiene. American Dental Association was formed in 1859, and 26 dentists met at Niagara Falls in New York to form the ADA, American Dental Association. So obviously, every dentist should, I think, go to the Niagara Falls, not only see the beauty of the Niagara Falls, but also to understand that ADA started there. In 1864, the rubber dam was invented by Sanford, And Lucy was the first woman to earn the dental degree from Ohio College of Dental Surgery, who graduated in 1866. The Wilkerson chair, the first pump type hydraulic chair, was introduced in 1877. And it was Dr. Washington Sheffield who manufactured the first toothpaste in collapsible tube. And he called it as the Dr. Sheffield's dentrifice, similar to the different dentrifices which even Group Pharma offers, as you can see there. Wilhelm Röntgen discovered the X-rays, and then came a new era in dental practice. In 18th century, the Federation Dentaire International (FDI) was formed, exactly 1900. The Oral Health Unit was established in WHO in 1948. In 1957, John Borden introduced the high-speed handpiece, which created or the air rotor. Then the Charaka Samhita, going back, stressed on toothbrushing. So toothbrushing is a very important aspect of oral hygiene. And in India, Dr. Rafiuddin Ahmad is considered the father of dentistry. He became the first president of All India Dental Association, and in 1920 founded the first dental college of India in Calcutta. Initially, the course was for 1 year, which then got changed to 4 years. So in the same way, Rashtriya Shikshana Samiti Trust in Bangalore has started with just a school with 6 students in 1940, but today it is an educational ecosystem of 20 institutions, of which the thousands of students have come out, including IAS and IPS officers, as you can see, including the famous cricketer Anil Kumble, and many such individuals who have made a mark in their life are from Rashtriya Shikshana Samiti. Belonging to this umbrella is the DAPM RV Dental College. So DA Pandu Memorial RV Dental College, which is located at JP Nagar, is known for its quality dental services. In 1992, the RV Dental College was formed, and it's affiliated to Rajiv Gandhi University of Health Sciences. There is a prestigious NAACA grade to this college. The college has a well-known, highly competent and dedicated teaching faculty and excellent infrastructure. This sprawling campus is 225,000 square feet in the heart, or you can see in one of the most important areas of Bangalore. And yes, UG, PG diploma, certificate, and even PhD courses are offered here. With 650 publications, 200 plus CDE programs, 60 plus faculty, it is definitely a blessed institution. And there is a vibrant community of the dental alumnus of RV Dental College, and that this is their Facebook page. Dental tourism is an important aspect because this is a catering to the dental tourists from across the world, and DA Pandu Memorial RV Dental College and Hospital is always serving world-class dentistry to attract dental tourists. There are a lot of researches that are updated, including with reference to the mouthwash Fresh Chlor, which reduces the viral load and can be used in dental practice. We offer interesting products like Omnident and also hand sanitizers, as well as one should know how the hand washing has to be done. So avoid the contact greetings and understand that we need to smile a lot, because that's why we are happy. Happy people smile 40 to 50 times a day, while children smile 400 times a day. Thank you very much from Group Pharmaceuticals. We definitely salute the dentist who is the smile and success creator. And a beautiful smile can change everything. So it's over to the speaker of the day, Dr. Priya Madam, for orofacial pain. And we have here with us Dr. Joshi Saab to take things onward. Thank you very much. Over to Dr. Joshi.
Thank you, Dr. Sunil. Dr. Subhash, can you take over?
Good morning, everybody. As usual, it was a very entertaining talk by Group Pharma, Mr. Sunil. And now I request Dr. Asha Iyengar to speak a few words before we begin our webinar. Over to you, ma'am.
Yeah, thank you, Dr. Subhash. So once again, welcome to the entire group for getting together this Saturday morning for the 7th of the series of webinars that we've conducted. So yes, like Dr. Subhash said, a very nice introduction by Mr. Sunil from Good Pharma. And again, thanks to Good Pharma who've been constantly supporting this webinar. And He's given so much of overview of the history of dentistry and so much of background. So dentistry has come a long way, and the specialty talk which Dr. Priya is going to give is a continuation of the orofacial pain series. So definitely it has shown the real advances that dentistry has made and what all the entire spectrum of dentistry can cover in terms of patient management. So again, welcome to all the participants and welcome to Dr. Priya for this part of our talk. Thank you.
Thank you, ma'am. Now I request Dr. Priya to deliver her webinar lecture. It's been a long journey till now with regard to orofacial pain, and we have seen that she makes the topic very simple and understanding becomes easy. She goes to the level of a student and explains things, which is the plus point of this webinar. Over to you, Dr. Priya. Good morning from our side. For you, it's a good evening.
Oh, good morning, everybody. Thank you for the warm introduction, Dr. Subhash, Dr. Asha, and Dr. Sunil. Thank you very much once again for the wonderful introductory talk that you gave on the history of dentistry. I always enjoy your talks, so it's always been a bonus. And of course, thanks to Group Pharma for supporting our talk for the last several sessions. So let me start my screen sharing. You guys tell me if you can see it. Can you see my screen?
Yes, we can.
Okay, all right, cool. Okay, then very good morning, everyone. Thank you all for coming and spending a part of your Saturday morning with us. Last time we talked about migraine. Today, let's turn to a very common type of headache. That's the tension type headache. We will also look at another headache entity that's called the medication overuse headache that sometimes also goes by the name rebound headache. So for today's game plan, we'll take a quick look to the epidemiology of tension type headache. We'll classify tension type headache, look at diagnostic criteria, pathophysiology, talk about the relationship between stress and tension type headache, the relationship between muscle tension and tension type headache, what treatment options we have, and we will definitely discuss the entity medication overuse headache. So moving on to the epidemiology of tension type headache, according to a study in Denmark, the lifetime prevalence is 78%. That is a lot of people. Majority of it is infrequent episodic tension type headache. What it is, we will see when we do the classification and diagnostic criteria. Just know that such an entity exists for right now. 2 to 3% of the population had chronic tension type headache that lasts a large part of the lifetime. 2 to 3% might seem like a large number, but in a country that has a large population, that itself becomes large number of people. I hope you can see that. Male-female ratio 5:4. Ladies, once again, if pain is a game, we win it, unfortunately. Starts at about the 20s, peaks at about 30 to 39 years of age. Next, we will talk about the possible risk factors of tension type headache. The first among that is poor self-rated health. So if you take a bunch of people and ask them the question, compared to your peer group, would you say your health is better, the same, or worse? If people say, no, I think my health is much worse compared to the people in my peer group, that's actually a risk factor for tension type headache. If somebody is not able to relax after work, the people who are tensed all the time, always tension. There are some people who will say, I'm not tensed because I'm not tensed. People like that, unable to relax. They also run the risk of having tension type headache. And people who sleep very few hours per night, the kind of people who say, I will sleep when I am dead, are also some of the people who are risking tension type headache. Next, we will move on to classification and diagnostic criteria. And just know that tension type headache gets a lower status than migraine. Migraine supersedes tension type headache. The question becomes, why should we classify headaches? We should because it helps us treatment plan better. The patient who gets headache every 6 months is very, very different than the one who has headaches 20 times a month. And I hope you can agree with that. Next, we will go on to the classification of tension type headache. So the first is infrequent episodic tension type headache. This is straight out of the International Classification of Headache Disorders. So what does it mean? Infrequent episodic tension type headache. It is 10 episodes that occur in a year. So that means less than 1 day a month on an average. So that's less than 12 headache days per year. The headache can last anywhere from 30 minutes to 7 days. It's bilateral. It's pressing or tightening quality, not throbbing, that is not pulsatile, mild to moderate intensity, not aggravated by routine physical activity like walking or climbing the stairs. It's very different from migraine, where routine physical activities worsen the pain. So when you talk to your patients, ask them what worsens your pain. If they don't say anything about routine physical activity worsening the pain, or if they say taking a walk makes me feel better, chances are they're not actually having a migraine. That is something I want you to tattoo in your brain. Tension type headache is not aggravated by routine physical activity. And to help you remember, I will quote to you something a patient told me some time back, and it has somehow stayed with me. And she was talking about her migraines. She said, when I have a horrible migraine, I have to sleep in a cool, dark room, and I hate everybody. And that's how people feel when they're having horrible migraine. The other thing with tension type headache is there cannot be a component of nausea or vomiting. And the patient can have either photophobia, which is light sensitivity, or phonophobia, which is sound sensitivity. It's one or the other. Whereas in migraine, patient has to have nausea or vomiting. Sometimes they can have both. Patient has photophobia and or phonophobia as well. Keep that in mind. This is infrequent episodic tension type headache. That means they have less than 12 headache days in a whole year. Next is frequent episodic tension type headache. It is very similar. The diagnostic criteria is very similar. That means it's bilateral. It's pressing or tightening quality. It's not pulsatile, not aggravated by routine physical activity, no nausea or vomiting, either photophobia or phonophobia. So what's different? What's different is they have more than one headache, but less than 15 headache days in a month for at least 3 months. Next, moving on to chronic tension type headache. It's very similar diagnostic criteria, but patient has headache more than 15 days a month on an average, and it has to be for more than 3 months. So that's more than 180 days a year. And the headache can last many hours or it can be continuous. They're literally in a soup of pain. That could count as chronic. They can have either photophobia or phonophobia. And here, what's different is they can have mild nausea. Mild nausea is okay, and it fulfills the criteria of chronic tension type headache. For acute, maybe not that much. And they cannot have either moderate or severe nausea or vomiting, which is again different from migraine, where patient could have one or both. Moving on to the clinical presentation of tension type headache. This is a little repetitive, but please bear with me anyway, because I want to make sure that the diagnostic criteria is tattooed in you guys' brain. So tension type headache is typically bilateral. It's pressing or tightening quality of pain. It can be mild to moderate intensity. It occurs either in short episodes or it can happen continuously. And the headache is not associated with typical migraine features like vomiting, severe photophobia, and phonophobia. And in the chronic form, only one of the latter two accompanying symptoms or mild nausea is accepted. And because of lack of accompanying symptoms and relatively milder intensity of pain, patients are rarely severely incapacitated because of their pain. The other thing to remember too is tension type headache is a very, very featureless headache. Because many secondary headaches may mimic tension type headache, the diagnosis of tension type headache requires exclusion of other organic diseases. So tension type headache can be thought of as a diagnosis of exclusion. Next, we will move on to the pathophysiology of a tension type headache. So peripheral mechanisms, if there is increased pericranial muscle tenderness, generalized pressure pain hypersensitivity, that's one very common finding with tension type headache. There are central mechanisms. There is central sensitization. Remember, we talked about central sensitization in the basic pain seminar. That was the first lecture. And what was it? Just to review it, let's just say you're having a really bad day in your clinic. Your assistants are not listening to you. Patients are not being compliant with their care. They want to haggle about the prices. You're having a bad day. Your procedure didn't go super awesomely ideal, and you're just having a bad day. You come home. Your kids want to show new dance moves, or they want to play with you. Your spouse wants to hang out. All you want to do is talk to the hand and lock yourself in a room. You're not able to enjoy a very pleasurable day or a pleasurable evening because you're having already a bad day in the office and your brain feels kind of off. So if your brain is primed with lots of noxious stimuli and the threshold for stimuli propagation is lowered, it's easier for pain stimuli to cross over. I hope you guys remember this. There could be some genetic mechanisms, could be psychological mechanisms. The other thing that we have to remember is with tension type headache, depression or anxiety, TM joint disorders can also be comorbid conditions. And that's something that I would like for you guys to remember. Next, we will take a look to muscle tension as a probable cause for tension type headache. So remember, we talked about episodic and chronic, infrequent episodic, frequent episodic, and chronic. So the conversion from episodic to chronic tension type headache, there is increased frequency of pericranial myofascial painful input. So the traffic keeps going up the spine, boom, 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 boom. So infrequent slowly becomes frequent. And then if the pain stimuli is continuously still going into the brain, boom, 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 non-stop, it can induce and maintain central sensitization of the innocuous stimuli. There is pericranial myofascial tissues are also sensitized that are normally not painful, now start to become painful, and then suddenly the patient is left with chronic tension type headache. Next, we will take a look to stress and tension type headache, and this is a model that was proposed by Cathcart. The model suggests that stress may contribute to chronic tension type headache through peripheral and central mechanism. Here, they've used the word stress to a stress process that involves stressors, a difficulty coping, physiological or psychological levels of arousal. Again, has peripheral sensitization. It enhances activation of the pericranial myofascial structures. Then again, there is central sensitization. I hope you guys remember that when we first talked about peripheral and central sensitization, I said when we talk about headaches, this will make a little bit more sense. And I hope it's making a little bit more sense now. There is wind up where the stimuli that are going into the brain get completely amplified. And then I hope you remember the concept of DNIC, that is diffuse noxious inhibitory control. We talked about it as a form of off switch that's mediated by the PAG-RVM system, where the stimuli that descends down from the brain can actually get attenuated, the off switch. I hope you guys remember that. So when you are having a lot of stress, you're sensitized peripherally, you're sensitized centrally, the off switch is not working. every signal that is going into the brain gets completely amplified, and then suddenly patient is left with a headache. I hope you can see how everything comes together in this slide. Now, how do we diagnose tension type headache? The diagnosis is typically based on history and normal neurological examination. Sometimes it could be helpful if the patient can keep a headache diary. You can write it down, that's not a problem. I believe some apps are available for download these days for having a headache diary. That might be feasible if patients prefer something digital or if you prefer something digital. The problem is how to discriminate between tension type headache and mild migraine. And that's actually a pretty reasonable question. So if a patient keeps a diary, it might reveal what triggers the headache. It might reveal what medications they're taking, whether they're using it, overusing it or not. And it also helps to establish a baseline against which we can compare if treatments are working or if they're not working. If the headache is strictly unilateral, consider cervicogenic headache. I know I didn't talk about cervicogenic headache much, but just to go over it real quick, I believe it was Dr. Subhash who asked the question. I'm sorry if I'm wrong, but anyway, I think the question was patients having headache when we palpate cervical muscles leading to pain. Is that possible? Yes, that could be cervicogenic headache. Cervicogenic headaches are typically unilateral, so that is something to think about. Again, if you have trigger point, sometimes it can also be called cervical myofascial pain. That is fine. Then trigger point injection would work. Physical therapy would work for patients like that. So keep that in mind. Then also identify what analgesics the patient is taking, because we will have to consider medication overuse, which we will be talking about later today, and that will require very specific treatment. Having said all that, if the patient is having strictly unilateral headache, there are bigger things that we also need to think about, like migraine, which is even worse, or cluster headache, or other trigeminal autonomic cephalalgias, which we will be talking about next time. Just remember that TACs are kind of rare. Migraine is not that rare. Cervicogenic headache is not too rare either. So keep all of those things in mind when you're developing your differential diagnosis. Now, brain imaging is necessary if a secondary headache is suspected. That is to say, if headache characteristics are not typical. Again, when you interview your patient, they have been suffering from headache for a long time, for example, and they say there is change in the way they feel the headache, there is a change in the pattern, there is a change in the phenotype, which means how it clinically looks. We talked about it last time. That's a big, big red flag. And at that point in time, brain imaging might be necessary. Again, as dentists, we may not be able to prescribe or read a brain image. That would be a good case where we would refer the patient to a neurologist or a neurosurgeon. Again, if the course of the headache attack changes, that is again another big red flag. And if there is persistent neurological or psychopathological abnormalities are present, then again, that would be another reason why we should try and get imaging. Like I already said, patients who have tension type headache, they can also have other comorbidities like anxiety and depression, and they should be identified and treated with the help of a psychologist or a psychiatrist. Patients may not comply with the treatment very well, so we might have to think about prophylactic treatment, and they may not comply with that either, and that's a problem, as it is with migraine. And it should be explained to the patient that frequent tension type headache can seldom be cured, and that's really not good news. But we can try to have some meaningful improvement, and that may be the only goal of the treatment at that point in time. And we can think about drug and non-drug modalities, which I will be talking about in just a little bit, but for right now. Next, we'll talk about treatment options. I think that was a good segue. So acute drug treatment, it treats the individual attacks of headache. It's much better for episodic tension type headache where pain is mild to moderate. and patient can self-manage using simple analgesics like paracetamol, acetaminophen, aspirin, or other NSAIDs. In chronic tension type headaches, they are often associated with stress, anxiety, depression. So simple analgesics are usually ineffective. Better that they are used with caution. Other interventions like non-drug treatments and prophylactic pharmacotherapy should be considered, and we will talk about that in this presentation, in this few slides. So, what are the simple analgesics that we can try for people who have infrequent episodic or somewhat frequent episodic tension type headache? These are things you guys already know. Ibuprofen, 200 to 800 milligrams, ketoprofen, 25 milligrams, aspirin, 500 to 1000 milligrams, naproxen, 375 to 500, paracetamol, about 1000 milligrams, and diclofenac, 12.5 to 100 milligrams. I hope we can all agree that we try to use the minimum effective dose for any individual patient. Next, we'll talk about combination analgesics. Analgesics can be combined with caffeine, codeine, barbiturates, and cannabis. I'll touch upon each and every one of them just a little bit. The first one is combination with caffeine. I think it's pretty widely available. Caffeine combined with ibuprofen, combined with Tylenol or paracetamol. Diclofenac, I'm not very sure if it is available. Naproxen, I'm not sure if it is available. But aspirin, Tylenol, ibuprofen, sure they're available. And that is something that you can try with your patient. There is supposed to be an increased efficacy of NSAID with 64 to 200 milligrams of caffeine. It's at a level recommendation B because compound medication can cause medication overuse headache in a patient. And I promise we will talk about medication overuse headache in this presentation. Just keep that in mind. Overusing a medication, especially compound medication, can aggravate a headache and cause a whole new different kind of headache. Codeine and other barbiturates. Are we seriously really considering this? I hope not, because there is potential for abuse and dependence and tolerance. Perhaps it's better we just lay off all of this. And if we are combining with the barbiturate, again, that's one of those things that can cause medication overuse headache. So I say just lay off. Next, with cannabis, it's a pretty interesting topic. And to the best of my knowledge, as of today, I don't think there is a commercially available combination, any cannabis combination with an NSAID that could be used in headache. I guess it seems a little more promising with neuropathic pain, especially CBD. I have used it, well, by used it, I mean recommended it to a patient, and that seemed to have helped her a little. There are some case studies. I will show a slide downstream where there are reports of effectiveness with migraine. But again, in the US, it's a Schedule 1 drug at the federal level. At some states have legalized it for recreational or medical use. But again, it's a Schedule 1 drug. That means it's very, very hard to obtain. Getting to do research with it is very, very difficult. And to the best of my knowledge, I don't think it is legal in India. You guys have to correct me if I'm wrong there. And like I said in one of the presentations with neuropathic pain, telling a desi auntie to say smoke ganja, I'm not sure how I feel about that. They might not really be accepting of it. Some of the younger patients might accept it a little bit, but I don't know. With all of the legality and other issues associated with it, I'd say use caution. So this was what I was talking about, some studies that talk about the use of cannabis or combination for treatment of headache. And basically, these are not very, very strong studies. As you can see, a case series, there are case reports. I see a randomized control study here somewhere. There are patient surveys. Again, case reports, case series does not make a very strong combination, a strong evidence-based thing for agreeing to use. Maybe in the future, there might be something, but I'm not sure about it right now. I know there are some groups of people who say cannabis is be all, end all, cure all for everything. And then there is another group of people who say it's a gateway drug, don't use it. That just leads you to hell. I personally don't have any strong opinion about it one way or the other. So I'm just going to wait for some good research, good quality research, and see what it says. Next, we'll talk about triptans, muscle relaxants, and opioids for treatment of tension type headache. Triptans are actually pretty useful for interval headache like a migraine. They're actually quite useful in cluster headache as well, which we will be talking about next time. Tension type headache, not really. And then no demonstrated use of muscle relaxants for tension type headache. And opioids are generally not recommended. Again, not very widely available in India. In some ways, it's something to be thankful for. But in the US, it can be quite widely available. That also causes medication overuse, headache, dependence, tolerance. It's just more problems than we need, I think. So it's a good thing. And I realized that since we are not face to face, I don't get to say my usual jokes to you guys. But I just put in one slide because I thought this was very funny. This is straight from PhD comics, piled higher and deeper. Lots of caffeine, lots of sugar. I don't know if my talk is keeping you guys awake. And hopefully, if we were in person, we would have all the caffeine and sugar. And we are not. I don't know. This is breakfast time. I hope you guys have coffee or tea and some nice sugary stuff to eat. I like this. It's a piled higher and deeper PhD comics. I have no financial interest. And trainees, if you're bored, you're feeling overwhelmed, for sure take a look at it. It will give you a little laugh. It really speaks to a trainee. Truly. Moving on, we will talk about prophylactic treatment for tension type headache. It's better to consider prophylactic treatment for chronic tension type headache or very infrequent episodic tension type headache. Take into account comorbid conditions like depression, anxiety. If the patient is overweight, definitely do think about that. And some of the options we have are antidepressants, NSAIDs, muscle relaxers, anticonvulsants, Botox. They have been tried, but there are very few placebo-controlled studies. So that's why making a comparison is very difficult. And personally, I feel that's an ethical gray area because if a patient is really suffering from pain and you want to compare efficacy of drug A versus placebo, withholding a treatment from someone who is actually having a lot of pain, I don't know about that. An IRB may not let it fly. But if you want to compare, say, treatment A with treatment B, treatment A with treatment C, B and C together, I think that might be a way to go about it. But if you are withholding actual treatment from a patient for a placebo-controlled study, that too on someone who's having a lot of pain, I think that's an ethically gray area, something to think about. So let's look to antidepressants as a prophylactic treatment for tension type headache. The first drug of choice is amitriptyline. That's a very familiar drug for us. Anywhere from 30 to 75 milligrams. Second drug of choice is mirtazapine, 30 milligrams. Venlafaxine is 150 milligrams. The third drug of choice is clomipramine, 75 to 150 milligrams. Meproteline or mianserine. And we'll take a look to some of the side effects. The other thing I forgot to mention was when you are treating patients prophylactically for tension type headache, try to discontinue treatment every 6 to 12 months. So every time you see a patient for the 6 months cleaning, see if you can try to discontinue the medication depending on the patient history. Having said that, side effects of amitriptyline, it's something we already know: dry mouth, drowsiness, dizziness, obstipation, weight gain. For mirtazapine, again, drowsiness, weight gain. And then for venlafaxine, there is vomiting, nausea, dizziness, loss of libido. The other thing to remember too is just because the list of side effects for any given drug is as big as my forearm, it doesn't mean a patient will suffer from every single one of them. They may suffer from one or two, maybe they won't suffer anything, or whatever they are suffering doesn't mean a big deal to them. So when you're in the titration period of a drug, be sure to ask the patient what side effects they are having and can they live with it, can't they live with it, and then do your treatment accordingly. For non-pharmacologic treatment, first of all,
Dr.
find
Priya
out
Madam,
what the
sorry to
triggers are.
intervene. I
Yes, sir.
request fellow presenters to please mute the audio. There is disturbance. Please mute your audio. Please continue, Dr. Priya Madam. Sorry for disturbing.
Okay, thank you, Dr. Sunil. So for non-pharmacologic methods, the most important thing that we can ever do to a patient is to educate them. Inform them what it is, talk to them about the pathophysiology, reassure them if there is no other underlying cause, and have them identify triggers. And this is where a headache diary would help. Some common triggers: stress, inappropriate meal times, caffeine, sleep disturbances, not sleeping enough, menstruation, hormonal substitution. Have the patient identify their triggers. That way you can control it. Some other non-pharmacological methods, they are EMG biofeedback, cognitive behavioral therapy, relaxation training, physical therapy, or acupuncture. We'll take a look to some of them now. With EMG biofeedback, it's actually level A for non-pharmacological treatment for tension type headache. It helps the patient to recognize and control muscle tension through a continuous feedback about muscle activity. Typically 3 phases: adaptation phase, baseline phase, and training and self-control phase, where the patient actually learns through the EMG how much tension would give them pain and what they have to do to relax their muscles. It's kind of cool, actually. Next is cognitive behavioral therapy. Like I said, patients who have tension type headache typically have also anxiety and depression. So it helps if they're able to consult with a psychologist or a psychiatrist. Help the patient identify thoughts and behaviors that trigger stress, and then challenge those thoughts and provide alternative thoughts and coping strategies. Next is relaxation training. Again, it involves a range of effective cognitive behavioral techniques like breathing exercises and meditation. But the thing is, there are not enough studies to prove their effectiveness. Again, going down the line of non-invasive physical therapy, there is improvement of posture, massage, spinal manipulation, exercise programs, hot and cold packs, ultrasound, electrical stimulation, and oromandibular treatment. One word about oromandibular treatment is the usual appliances, full arch appliances. It is not to say that putting a patient in a full arch appliance will take away their tension type headache or migraine and things of that nature. And I'm definitely not saying that. And I want you guys to keep that in mind. What I am trying to say is, many times with tension type headache, temporomandibular joint disorders, intracapsular, extracapsular, especially extracapsular, can be a comorbid problem. So if you're treating a patient and the patient has a TMD, you are very well advised to treat the TMD, and an appliance is one of the things that we go to, a conservative thing that we go to, and that is something that you should reach to. Please keep that in mind. You're treating the whole patient. See the whole picture. See the gestalt of the patient before you actually put them treatment. These are all the menu of options that we have available for a patient. I really don't want the takeaway from you guys that putting a patient on an appliance will cure their tension type headache. I'm not really saying direct cause and effect relationship here. See the whole patient, tailor the therapy according to their needs. I will repeat it. See the whole patient, tailor the therapy according to their needs. I can't make that any more clear, okay? Now, acupuncture and nerve blocks. Again, we need more studies to say for sure if acupuncture would be helpful, but unfortunately, greater occipital nerve block is not very effective. Next, we will move on to a new entity called medication overuse headache. It's an interesting animal, actually. So what it is, the consensus all over the world for medication overuse headache is worsening of a pre-existing headache due to overuse of one or more acute medications. So that means for you to diagnose a patient as having medication overuse headache, first of all, there should be a diagnosis of primary headache. And then if the patient is popping medication like Halloween candy, then you can say perhaps they might be having medication overuse headache. There are actually specific diagnostic criteria for it, and I will be talking to you about it in just a second. But just so you know, medication overuse is a secondary headache. That means it is caused by something else, and then that something else has to be a primary headache and patient overusing acute medications. It was first described in 1930s. It used to be called rebound headache, analgesic abuse headache, just so you get an idea of how the name came to be. More recently, it's been told that it's not necessary for the underlying disorder to be resolved for the diagnosis to be made. And the diagnosis is by medical history. So make sure you have the diagnosis of a primary headache. And then depending on the patient medication, the usage, dosage, you would diagnose medication overuse headache. So let's look at the diagnostic criteria right now. Medication, again, this is from International Classification of Headache Disorders. Headache occurring more than 15 days a month in a patient with pre-existing headache disorder. And the patient has to overuse medication for more than 3 months of one or more drugs that are used to treat symptomatic headache. So there are two things that need to happen here. Headache has to occur, first of all, more than 15 days a month. That is very definition of chronicity. And then patient has to regularly overuse one or more medications for symptomatic treatment. And that has to happen for over 3 months. So what are the specific medications and how many days? So if the patient is using for more than 10 days, for 3 months, whether it's ergotamine, triptans, opioids, or combination medications, it's more than 10 days, then the patient meets the criteria for medication overuse headache. But if it is simple analgesics like acetaminophen or any NSAIDs or aspirin, it has to be over 15 days, again for 3 months. So if it is simple pain medications, paracetamol, NSAIDs, aspirin, it's more than 15 days. But if it is a combination medication, opioids, triptans, or ergotamine, it is more than 10 days and it has to be for 3 months. And remember, there also has to be a component of a primary headache. What are the risk factors? There is very, very low risk for medication overuse headache with respect to ergots or triptans, and highest for opioids. In the US, it's pretty common for doctors to prescribe a medication called Furoset. Notoriously, it's an opioid combination, notoriously causes medication overuse headache. So when taking headache history, the patient says Furoset, brain already goes, oh, they're probably having medication overuse headache. And migraines, they're most often complicated by medication overuse headache. So not only is patient suffering from migraine, they're also having medication overuse headache. More often than not, there is also a component of TMD, about 40 to 50%, I think. That's what the literature says. So now you can imagine how much pain a patient is suffering. Kind of feel sad. What's the pathophysiology of medication overuse headache? Unfortunately, it's not very well understood. There are some theories, central sensitization. Remember, bad day, coming home, your children and spouse wanting to have a good day with you, and you're angry. Central sensitization. Increased susceptibility to cortical spreading depression. We talked about it last time, where there is K plus in the cells, sort of diffuses in the brain. There is upregulation of mediators, could be because of genetics, but again, the pathophysiology is not completely understood. Maybe that is something that trainees can consider doing PhD in. That might be nice. So how do we treat it? Again, education is the best thing that we can do to a patient to prevent medication overuse headache. I will talk, when we talk about prophylaxis, I'll talk about it a little bit more. Personally, and again, this is my personal opinion, I think it's easier to prevent medication overuse headache than to treat it. So when you are giving a patient treatment or when you're giving them information about what's going on with them, mere fact of telling them that taking overtaking the medication is worsening or causing some of their headache, that itself will caution them, and patient will be a little bit more cautious about taking the medication. When I first started my residency, one of the very first patients I saw had medication overuse headache. She had, again, concurrent TMD. And when I saw her for her 1 month recall appointment, she said very clearly, I'm not taking as much medication because you told me that would worsen my headache. And because of that, I've been okay. So educate the patient, tell them what's going on. That's one of the best things that you can do for them. Next is withdrawal and prophylaxis. We'll talk about it in a little bit detail right now. In education, I already told you, talk to the patient, tell them the relationship between headache and medications. Also educate them on lifestyle, stress, obesity, smoking, how they are all interrelated. And whatever you do, know all the products that patients are taking so that you can educate them better. Next is withdrawal. There's something to think about, and I personally don't have a strong opinion about it. Is medication overuse headache cause or consequence of headache chronification? Think about that and see how you feel about it. Is it a cause or consequence of headache chronification? So the worldwide consensus is we have to completely withdraw the patient of acute medications. But when you try to tell a patient completely stop all the medications that you're taking that's helping you with the headache, I swear they will look at you like you sprouted 5 heads at once. Again, NSAIDs, ergots, triptans, you can abruptly withdraw because there are not a whole lot of secondary effects. It's okay. But you can't abruptly withdraw opioids, benzos, or barbiturates because there would be withdrawal symptoms. And for those medications, slow withdrawal is much better. And in some cases, whether it is NSAIDs or ergots, or if they are opioids or barbiturates, patient may very well need inpatient treatment for withdrawal because if they take away all the medication, they are going to need something to help them with pain. At that time, inpatient would be a better way to go. Next is prophylaxis. Starting prophylactic treatment is important to prevent chronification. So if a patient has frequent episodic headache or if they have chronic headache, maybe something to think about would be starting prophylactic treatment. So if you are starting prophylactic treatment, consider medical history, headache history, what other drugs they're taking, what side effects they're having, comorbidities, contraindication before you start. And as always, talk to the patients about lifestyle, smoking, sleep, stress, diet. The prognosis for medication overuse headache, overuse leads to poorer quality of life and poorer prognosis for the primary headache itself. And that's the reason why I said it's just better to prevent it than to treat it. And if there is 50% reduction of headache, it's considered good endpoint, 50 to 70%. That's something, I guess, if you're having a lot of pain. And if the patient is able to maintain the withdrawal for more than a year, it also is a good predictor for long-term success. So the key points in this presentation, remember that tension type headache is a very, very featureless headache. Diagnosis is kind of based on exclusion. And be sure to question the patient about neck pain, cervicogenic exaggeration, and also definitely talk to the patient about what medications they are taking, what's the dosage, what's the frequency, because you do have to consider the diagnosis of medication overuse headache. And if that is playing into the patient's overall pain condition, that is something you have to treat as well. With that, I will take questions.
Yeah. Again, Dr. Priya, it was a complicated matter made into a very simple presentation. This is my personally, I have one thing, like in US or anywhere, about any study or research being done on yoga and its effect on these chronic issues. Do you have any idea about use of yoga in managing these conditions?
I wouldn't say yoga specifically, but I think there are studies that relates exercise and pain.
Okay.
But
You're not.
I am not really aware if yoga, specifically yoga, but generally having a healthy lifestyle, pain, diet, pain, there are a few studies, yes.
Okay, but not specifically yoga.
Not that I am aware of. There might be, but I am not aware of it.
Okay. What do you feel like? Do you feel there is any kind of benefit for a patient with some yogic exercises? Like,
Again, this is my personal opinion, right? This is not backed by any studies. It's my personal opinion. Anything that will give the patient more mobility, exercises, encourages them to have a healthy lifestyle, good diet, it's worth trying. Especially for patients who say, I don't want to take medication. I don't want to see the physical therapist. A lot of patients would be open to the possibility of doing yoga. They're gentle. Of course, you can also do yoga very vigorously and work up a sweat. But I'm a fan of anything that helps better lifestyle for a patient. So it couldn't hurt.
okay. Okay. Like you're talking about this biofeedback, right?
Yeah.
So actually, how they do it, they combine with sleep studies, or it is kind of.
No, biofeedback is a specific mechanism, to the best of my knowledge, psychologists use, and they put EMG leads on a patient. And the patient will be able to see in the monitor how much muscle tension they are having.
Okay.
And then using that as a guide, they learn to relax. And as they are relaxing, they can see the needle going down. They can actually physically see the stress and the tension in the muscle becoming less. And the patient learn to regulate themselves. So, how much do I have to clench, or how much muscle tension do I have to give? Shoulders, arms, legs, back, things of that nature. It's led by EMG, basically.
If I can intervene a bit here, there is a question from our constant attendee, Dr. Murali sir.
Hi, Dr. Murali.
He has been. Okay, the question goes like this. In pre-existing chronic respiratory conditions like asthma, most of the drugs that you listed out, they are out of scope.
Yes.
So what after that? And he's talking about tropical countries like India. And he's also added a comment there that there was not even a single moment of dullness in the whole presentation. It's a compliment to you, Dr. Priya.
Thank you, Dr.
Okay,
Murali.
go ahead.
That's very kind of you. So going to the question, the use of NSAIDs in chronic asthmatics, I think there are some studies that say, depending on what medication is, it may or may not aggravate asthma. But again, I totally understand where you're coming from. I don't particularly feel very comfortable prescribing NSAIDs to chronic asthmatics. So again, depending on the frequency of headache, let's say they get a headache once or twice a month, paracetamol may be a way to go, acetaminophen may be a way to go. Or if they're having lot of chronic headache, we might have to consider the possibility of going prophylactic treatment where amitriptyline, I think, should be okay. Heart and cholinergic problems. Oh, no, you can't. You can't do amitriptyline. Sorry, I take it back. It's totally contraindicated. Sorry, I said that. Then we might have to consider a non-pharmacological treatment at that point. Hope that helps.
Okay. Yeah. Okay. So again, same thing like last seminar I had asked you. In US dental offices, they deal with headaches, or they refer it to special pain clinics?
That's a good question. It depends on the skill and the training of any specific doctor. So let's say a doctor has skills to treat chronic pain, you can do it in your office. It's not a problem. If not, it's probably better to refer out. A neurologist is a good referral person, or primary care doctor, neurologist, they're good referral. But that's a very individual question that you would ask a specific provider. I don't think there is an answer that sort of encompasses everything.
Okay. Thank you, Dr. Priya. Thank you.
Thank you, Dr. Subhash.
Thank you. Asha ma'am, do you have any comments to make?
Yeah, this thought I'll ask Priya. Do you have any experience in this low-level laser therapy in orofacial pain?
I have read some studies regarding low-level laser therapy and its connection to muscle pain. The one thing that stuck out from the studies that I have read, there is no consensus with what kind of laser, how many sessions of treatment, and how long do you have to do the treatment, the duration of treatment. Is it half an hour 3 times a week, or is it 2 hours once a week, or is it 5 hours once a month? There doesn't seem to be any consensus. But the papers I studied, they have given a good result, I guess we can say that. But again, there is no consensus as to frequency or duration for low-level laser therapy and muscle pain.
Yeah, thanks.
Now I request, I think we are at the end of our session. So I request Dr. Seema Patil to give a vote of thanks.
Hello, Dr. Priya. It was a very elaborate and detailed explanation you gave us on tension type headache and medication overuse.
Hi, Dr. Seema.
Hi. Thanks a lot once again. And I would like to thank Dr. Joshi, who's been instrumental in organizing this series of webinars. And of course, Mr. Sunil, who has constantly been providing the platform for organizing the webinars. And definitely our Asha ma'am, who's always been very encouraging and supportive whenever we go to her and tell her, ma'am, we all want to organize a CD or webinar. She's never said no to us. And Dr. Subhash, who's been constantly agreeing to moderate these webinars, and he's been so actively participating in these webinars and involving himself with the questions. Thank you all once again, and we'll meet you on 24th, that is Thursday, for the next webinar. Thank you once again, Priya.
I personally
thank you, Dr. Seema. Thank you, everyone.
I personally thank everybody for the kind comments and support to Group Pharma. So I take the permission of everybody to close the webinar. Can I close?
Yeah. Please, a gentle reminder to all the participants today, please log in again on 24th. That is our last session of our series on orofacial pain. Whatever doubts you had throughout, or if you have something that you have left out, you felt you couldn't understand, please come up with the questions on the last session. I extend a wholehearted thanks from the side of Karnataka State Branch of IDA, Bangalore Branch of IDA, to Dr. Priya for being here with us throughout and taking us through tension type headache without tension. Thank you.
Thank you very much. Dr. Joshi, sir, shall I close?
Yes.